Today we will talk about the amenorrhea. Amenorrhea is defined as the absence of the menstruation, and the amenorrhea is divided into main two types. The first one is false amenorrhea, and the second is true amenorrhea. False amenorrhea is also called as cryptomenorrhea, and false amenorrhea, the endometrium shed, but the tract is blocked, and it is usually present congenitally. And true amenorrhea, we divide it into two types. One is physiological, which is normal, and the second one is pathological. So the physiological amenorrhea occur before the puberty, during pregnancy, and during exclusive breastfeeding. And the pathological causes of amenorrhea, we have two types. One is primary amenorrhea, and the second one is secondary amenorrhea. So, primary amenorrhea is defined as the type of amenorrhea in which the female fails to menstruate by passing the age of 16 years or by passing the age of puberty. And secondary amenorrhea, there is absence of menstruation for more than 6 months in a normal female of reproductive age, and it is not due to pregnancy, lactation, or menopause. Means that in secondary amenorrhea, the female fails to menstruate for more than 6 months in a normal reproductive age. And oligomenorrhea is defined as the irregular periods for more than 35 days with only 4 to 9 periods in a year. Now let's talk about the etiology of the amenorrhea. So there are different conditions that cause amenorrhea, and it can broadly be classified into the following categories. Number first is the reproductive outflow tract disorder. Second one is ovulation disorder. Third one is pituitary disorders, and the fourth one is hypothalamic disorders. So the first one is reproductive outflow tract disorders that causes amenorrhea. They include Asherman syndrome, in which there is scarring of the uterus, Mullerian agenesis, in which there is pelvic formation of uterus and vagina. There may be transverse vaginal septum, imperforate hymen, which is the most common cause of reproductive outflow tract disorder. There may be androgen insensitivity syndrome. There may be congenital absence of the vagina. Second one is ovulatory disorder. So, an ovulatory disorder, there may be an ovulation which most commonly occur in a polycystic ovary syndrome. And polycystic ovary syndrome is the most common cause of the oligomenorrhea or amenorrhea. It also occurs in the Turner syndrome. There may be premature ovarian failure occur or resistance ovary syndrome occur. In premature ovarian failure, there are non-viable follicle in the ovary. So they have low estrogen and the high FSH and LH level. In resistance ovary syndrome, we have viable follicle in the ovary, but they are non-responding to the FSH and LH level. Now, yeah, let's talk about the pituitary disorder. So, the pituitary disorder that causes amenorrhea are the pituitary adenoma, which is the most common pituitary cause of amenorrhea. And the most common pituitary adenoma is prolactinoma, which secrete excessive prolactin level, and it causes amenorrhea. The other causes include surgery, the Sheehan syndrome, which is also known as postpartum and ischemic necrosis. There may be empty cell tarsica syndrome or craniopharyngioma, which causes the amenorrhea. Next is the hypothalamic disorders. So they include the functional causes, which include stress, anorexia, or excessive exercise, and the non-functional causes that may include the space-occupying lesion, any surgery done, or the Kallmann syndrome, encephalitis. In such cases, there may be decrease in the hormones level, and they may lead to the amenorrhea. Now let's talk about the evaluation of a patient with amenorrhea. So first of all, we will take a history and then do examination. And history, ask about the age of the patient, the developmental history, take a detailed gynecological history and the detailed obstetrical history. Also ask about contraceptive history, and also ask about any history of chronic disease the patient have. Also ask about whether the patient have a history of any chronic or excessive exercise, or there is any history of anosmia, any significant past medical or surgical history. Also ask about the presence of the premenopausal symptoms. Also ask about whether the patient is using any medication or not. Also ask about the family history of premature menopause, and also ask about the development of any viralizing sign, galacturia. Also take a psychological history and any recent stressful event, any history of cyclical pain. In examination, we do the body mass index, calculate the body mass index. We also do the visual confrontation test for visual field defects, and if there is bitemporal hemianopia, which is present in case of the polyctinoma pituitary adenoma. Similarly, we also assess the patient for the stigmata of endocrinopathies or the signs of the Turner syndrome. Similarly, we also look for the evidence of the virilization, and we also do abdominal examination and the pelvic examination. On pelvic examination, we may have either imperforated hymen, which may be a cause of amenorrhea. There may be blind in vaginal septum, or there may be absence of the uterus occur or vagina, or there may be the evidence of ectopic apex, which occur in the hypoestrogenism within the lower genital tract. Now let's talk about the management of the amenorrhea. So if a patient present with a history of primary amenorrhea, we take a detailed history, do physical examination, by abdomen and pelvic examination and investigations. We assess for the FSH level, HCG, for pregnancy. We also do the prolactin hormone level, serum TSH level, and similarly we also do the pelvic ultrasound, and we also do the pregnancy test. If the pregnancy test is positive, then pregnancy is the cause of the amenorrhea. In case of primary amenorrhea, if the uterus is absent, then under the karyotypy and serum testosterone level. If the karyotypy is 46 XX, it indicates the Mullerian agenesis, which is also known as a Rocketensi syndrome. In Mullerian agenesis, there is a congenital absence of the vagina and the uterus, and but there are normal breast development and normal FSH, and the serum testosterone is in the female range. But if the karyotypy is 46XY, there may be either androgen insensitivity, 5 alpha reductase deficiency, and androgen insensitivity syndrome. We have the female phenotype, and the serum testosterone are in the male range. And 5 alpha reductase deficiency, the female we have female phenotype are either ambiguous genitalia at birth, and the serum testosterone is in the male range, which causes virilization at the puberty. Now, if the uterus is present with a normal to low FSH level, then assess for the breast development at the tenor stage. If the tenor stage is more than 2, then look for the reproductive tract abnormalities, like there may be imperforate hymen occur, transverse vaginal septum occur. But if the breast development at the tenor stage is less than 2, so then we do the repeated checking of the FSH level and the LH level. And similarly, we also do the pituitary MRI to rule out any mass or tumor in the brain. If there is low FSH and LH level, then there may be constitutional delay of the puberty occur, or there may be congenital GNRH deficiency which occur in the Kallman syndrome, or there may be hypothalamic pituitary disorder occur. But if we have low LH and FSH as normal, it may occur in the functional hypothalamic amenorrhea or hypogonadotropic hypogonadism. It may also occur in the systemic diseases like celiac disease or type 1 diabetes. Similarly, it may also occur in stress or excessive exercise. Now, if the uterus is present with a high FSH level, then evaluate the blood pressure. If patient has a hypertension and secondary sexual characters are absent, then evaluate the patient for congenital adrenal hyperplasia that occur in 17 hydroxylase deficiency. And congenital adrenal hyperplasia, the patient has signs of hyperandrogenism due to the congenital absence of the certain enzymes involved in the steroidogenesis. If the patient has no hypertension and the secondary sexual characters are present, then under the patient karyotypy. There may be primary ovarian insufficiency and case of 46XXX and gonadal dysgenesis that occur in 46XY and Turner syndrome whose karyotypy is 45X. And management of the secondary amenorrhea. So the management of secondary dysmenorrhea is guided by the diagnosis and the fertility wishes, and the management options are treat the underlying cause and attain a normal BMI by doing regular exercise, attain a healthy lifestyle, and take care of the nutrition. For prolactinoma, we have different treatment options. First one is the medical treatment, in which we give the patient dopamine analogs like carbagolin and bromocriptine, which inhibit the prolactin synthesis. And if the patient fail to respond to the medical treatment, then we have surgical treatment that involve transpenital surgical resection. And similarly, we also do the radiotherapy or chemotherapy if surgery is not possible. In case of hormonal deficiency that occur in premature ovarian failure, we give the patient hormone replacement therapy, and we also treat the specific endocrine disorders. And if there is a genital tract obstruction, in case of cervical stenosis, we do cervical dilation, and we also do hysteroscopic resection. And in cases of imperforated hymen, we give incision in the hymen, and the incision given is the cruciate incision. Cruciate incision is a cross type or plus type of the incision given in case of the imperforated hymen. So it was all about the detailed management of the amenorrhea.